Good morning. We are discussing HIV and AIDS. So what we are discussing? We will be discussing history, what is the scenario, what is the virology, its modes of transmission, its immunopathogenesis, natural history and its stages, its clinical features, its mucocutaneous manifestations, its diagnosis and its treatment, and what are the post-exposure prophylaxis and what are the protections. In history, it was first diagnosed in 1981 by Joel D. Weissman in a homosexual patient presented with Kaposi sarcoma. In 1983, the causative organism was isolated and termed as lymphadenopathy-associated virus. In 1984, Robert Gallo coined the term HTLV3, that is human T-cell lymphotropic virus. In 1986, International Committee of Taxonomy named the virus as human immunodeficiency virus. So the history of India. In 1986, the first case was diagnosed in India, and in 1987, the first antiretroviral drug, azithromycin, was invented. In 1989, compulsory testing of blood for HIV is done before transfusion and all procedures. In 1995, availability of protease inhibitors, beginning with highly active retroviral therapy, started. So, with other drugs, the protease inhibitors are added, and in 1995, the heart therapy was started. In 2017, there was introduction of test and treat policy by National AIDS Control Organization, where there is initiation of antiretroviral therapy free of cost once the person is detected from HIV positive. So, what is AIDS and why it is a hazard to human? So, the majority mode of transfer of HIV is sexual. So there will be urge and physical intimacy and fundamental in all human beings. So we have to we have to protect such physical intimacy with multiple partners. There is mother to child transmission also. There is long incubation period. A person with no knowledge of being infected can infect others unwillingly, because there is a very long period that the patient doesn't know that he is suffering from AIDS or HIV. He is infected of, or he or she is infected of HIV. And till now, there is no cure. The disease present lifelong. So, what are the prevention? Prevention depends upon the self-protective sexual behavior mainly, which protects others. It is a very challenging for change. It is very challenging to change the human behavior, and the protective vaccine is yet not available. So it's a very serious threat to human population. So what is the global scenario right now? Till 2020, the people infected with HIV are 37.7 millions, of which adults and children newly infected with HIV are 1.5 million per year, and the deaths related to AIDS among adults and children is 0.78 million. So when the epidemic started, since then, around 79.3 million persons are infected with HIV, and 36.3 million people have died with AIDS-related illness since the start of epidemic. So it's a very big number according to the infection and its conversion to death. Almost 50%, more than 50% people died due to its complications. So till now, people having access to antiretroviral therapy are 26.5 million to 27.7 million. So what epidemic is doing in India till 2019, 23.48 people were infected with HIV, and estimated adult prevalence in 2019 was 0.22%. Estimated people newly infected with HIV in 2019 are 69,000, and its related death in 2019 was 58.9 thousand. So what is this virus? This virus belongs to family Retroviridie and genus lentivirus, a genus of slow virus with long incubation periods. So what are the retrovirus? Retrovirus are the RNA virus that infect the person, and through its own RNA they convert to DNA with reverse transcriptase enzyme. So, what was the origin of HIV? Scientists identified a type of chimpanzee in wild West Africa as a source of HIV infection in humans. Chimpanzee version of immunodeficiency virus is also called as simian immunodeficiency virus. Most likely was transmitted to human and mutated into HIV when humans hunted these chimpanzee for meat, and when they came in contact with their infected blood. Over decades, the virus has slowly spread across the Africa and later into the other parts of the world. You can see the structure of human immunodeficiency virus. There is envelope coding gene GP120, which is a surface glycoprotein. Then another envelope transmembrane glycoprotein TM named as GP41. Then GAG associated matrix protein P17. Then GAG capsid core shell P24. And protease PR9 polymerase RT and RNase in 32. RNA two molecules. There are two molecules, and all these things are important because all the drugs which are acting against or which are using for HIV acts on all these proteins or antigens. So what are the types of HIV we have? We have two types of HIV, HIV-1 and HIV-2. HIV-1 is a major cause of disease all over the world. There are 11 subtypes of HIV-1, A to K. The subtype C is prevalent in India. HIV subtype C is associated with sexual transmission, and subtype D with intravenous drug users and homosexuals. Then HIV-2 is restricted to certain geographic areas like West Africa. Transmissibility lesser, longer incubation period, and better diagnosis than the more virulent HIV-1. HIV-2 is interestingly resistant to most non-nucleotides reverse transcriptase inhibitors. Circulating recombinant forms, occasionally two viruses from different subtypes infect the same cell in an infected person and result in recombinant virus strands that may transmit within a population. So, how is the infection occur and how its entry takes and how the replication occurs? We know how the infection occurs when HIV enter as receptor binding protein CD4. Then the fusion occurs, then uncoating of the virus, the reverse transcriptase enzyme integrate with the DNA, and through interacting with the host DNA, through translation, it converts into viral protein. So, through the DNA of host, it generates its own viral proteins, and new virus are generated, and then maturation occurs. What are the peculiarities of HIV? Heterogeneous and genetically diverse disease. It It is a heterogeneous and genetically diverse disease and has a variety of biological, serologic, and molecular features. It is predominantly lymphocytotrophic to CD4 T helper cell. Also, it is incurable. It's the most important characteristic. It persists in century and reservoirs, right? So majority of them being the resting memory CD4 T cells, which have a long half-life and are uninfected by antiretroviral therapy. Uh, Also, a particular feature of this virus is this evades immune response. It multiplies in presence of antibodies and continues high-level viral replication occurs even during clinical latency. It is mutagenic and replication error is prone, leading to drug resistance and difficulty in preparation of vaccine. What are the body fluids which contains HIV? Okay, the blood, semen, vaginal, cervical secretion, breast milk, amniotic fluid, cerebrospinal fluid, pleural, pericardial, peritoneal fluids, any body fluid contaminated with blood contains HIV. And body fluids which no HIV or no low HIV concentration are saliva, tears, sweat, urine, and stool. What are the modes of transmission? When HIV infected body fluids come into contact with uninfected person through different routes. What are these routes? Sexual, from infected to normal partner by unprotected sexual act, through blood, transmission of blood and blood products, accidental transmission in healthcare setup from needle, syringe, instruments contaminated with infected blood, contaminated syringes and IV drug abusers, from parent to child transmission. A pregnant woman can transmit it before delivery, during delivery, or after delivery through breastfeeding. What are the dynamics of sexual transmission? Chances of male to female transmission is 5 to 6 times higher because the female is the receptive partner with infected cells in the semen are directly gained into female genital tract. Reproductive tract infections are common in women, which make the mucosa more susceptible to HIV transmission. Presence of STD increase the risk of HIV by many times due to mucosal inflammations, microabrasions. Receptive anal intercourse has highest risk of transmission as anal mucosa is more fragile and there is greater chances of injury. What are the routes of acquisition of HIV in India? That means what are the modes of transmission majorly in India? It's due to heterosexual, 88%, then homosexual, parent to child, IV abusers, blood to blood products, and unknown. So what are the efficiency of transmission through exposure? That means what are the chances if you have the kind of act so that the transmission has the chances to occur. The blood transfusion has the highest chances of transfusion if the infected blood is transfused. That is 90 to 95%. Perinatal has also high content, 20 to 40%. Then sexual 0.1 to 10%, vaginal 0.05 to 0.1%, receptive vaginal intercourse that is 0.1 to 10%, insertive vaginal intercourse 0.1 to 1%, anogenital sex total risk is 0.065 to 0.5. Receptive one has more chances 1 to 30%, and insertive anal intercourse has less chances 0.1 to 10%. Orogenital sex 0.05% to 0.1%, and others are IV drug use, needle stick exposure, mucous membrane splash, and oronasal area. Immune system of human comprises of cell-mediated immunity mediated by T cells and humoral or antibody associated by T cell. There are two types of T cell important in immunopathogenesis of HIV: helper T cells and suppressor T cells. Helper T cells, what is they are CD4 cell conducting an orchestration of immune system is primary target of HIV, thereby deranging the whole immune system. Killing of CD4 lymphocytes results in marked immunosuppression, leading to an increased chance of opportunistic infection by common cells, environmental contaminants, and non-pathogen, as well as malignancies associated with suppressed immunity. What are the cells which bear CD4 receptors and thereby susceptible to HIV? In skin, there are Langerhans cells, fibroblasts, megakaryocytes, and basophils. Neuronal cells, they are astrocytes, oligodendrocytes, capillary endothelium, microglial cells. Hematopoietic cells are B lymphocyte, T lymphocyte, natural killer cells, eosinophil, monocytes, macrophages, dendritic cells, promyelocytes, and Kupffer cells. Others are gut-associated lymphoid tissue, colon carcinoma, bowel epithelium, renal epithelium, thymic precursor cells, retinal cells, and placental trophoblast. What is the natural history of infection? After infection, 4 to 8 weeks, there is a window period where HIV load increases. Then there is decrease of HIV load, and after 8 weeks, antibody starts to appear, but then gradually up to several years, the HIV load is stable, and then it increases, and CD4 count falls. So this is the year-wise counts of CD4 and infection and HIV RNA. You can see after infection, there is after 2 years, there is gradual decrease in CD4 counts, and in generally there is increase of HIV syndrome. Then there is fall, and then again when CD4 falls, then constitutional symptoms and opportunistic diseases increases due to increase of HIV RNA. There are 4 stages of infection: clinical stage 1, clinical stage 2, clinical 3, and clinical 4. Also, there is a stage where primary HIV infection occurs and seroconversion illness. So you have just fever, that's it. Then all the stages depend upon the CD4 count. When the clinical stage 1 is coined when the CD4 count is greater than 100, there is a asymptomatic, the stage is asymptomatic, and there might be generalized lymphadenopathy. When CD4 counts fall between 200 to 500, then there is an unexplained weight loss and herpes zoster occurs. When CD4 count is below 200, unexplained weight loss, diarrhea, fever for long period. And when CD4 count is less than 50, then AIDS defining opportunistic infections and malignancies occurs. So we are seeing the stages: primary HIV infection, there is acute retroviral syndrome, which is also called as seroconversion illness, 2 to 4 weeks after the initial exposure. 50 to 90% of patients experience seroconversion illness in the form of acute febrile illness, like flu-like syndrome, associated with lymphadenopathy, pharyngitis, or there may be orogenital ulcer or maculopapular rash or meningoencephalitis due to rapid proliferation of HIV in blood and lymph nodes. The HIV can be detected by HIV RNA or DNA test. HIV antibody tests are negative in this window period because no antibody forms in this period. Then clinical stage 1, which is also asymptomatic, lasts for 2 to 10 years and an average of 8 years. Mainly asymptomatic, we can find primary generalized lymphadenopathy defined as enlarged lymph nodes greater than 1 centimeter involving at least 2 contiguous sites other than inguinal loads in the absence of an obvious cause. Stage 2 is a mild symptom. There is moderate unexplained weight loss, less than 10% of presumed or measured body weight. There are recurrent respiratory tract infection, like in skin, there is presence of herpes zoster, papular pruritic eruption, seborrheic dermatitis, In mucosa, there is angular cheilitis and recurrent oral ulceration. In stage 3, there is advanced symptoms characterized by advancing immunosuppression and opportunistic infections. There is unexplained severe weight loss, which is greater than 10% of the body weight, unexplained chronic diarrhea lasting more than 1 month, persistent fever lasting more than 1 month, persistent oral candidiasis or oral hairy leukopenia, pulmonary tuberculosis, severe bacterial infection like pneumonia, pyomyositis, bone infection, meningitis, or bacteremia, acute necrotizing ulcerative stomatitis, gingivitis, or periodontitis. There is unexplained anemia, which is hemoglobin less than 8 grams per deciliter, neutropenia, and chronic thrombocytopenia. Then occurs clinical stage 4, which is have severe symptoms, also called HIV wasting syndrome, TB, extrapulmonary tuberculosis, disseminated non-tuberculous mycobacterial infections. There is infection of pneumocystis jejuni, recurrent severe bacterial pneumonia, herpes simplex sonic infection of greater than 1 month's duration, candidiasis, oroesophageal, Kaposi sarcoma, cytomegalovirus infection, toxoplasmosis, HIV encephalopathy, extrapulmonary cryptococcosis, including meningitis, progressive multifocal leukoencephalopathy, chronic cryptosporidiosis, chronic isoporiasis, invasive cervical cell carcinoma. What are the opportunistic infections? These are infections in immunocompromised patients caused by microorganisms which are usually non-pathogenic to normal immune system. These can be common cells, environmental contaminants, or non-pathogens. So what are the most HIV-related infections commonly we encountered in India? In CNS infection, bacterial is tuberculosis and syphilis, and viral is cytomegalovirus. In GIT, bacterial infection of Salmonella typhi is more common. In lung, tuberculosis, bacterial respiratory infection of Mycobacterium avium complex, cytomegalovirus pneumonia, mucocutaneous infection. We have bacillary angiomatosis, pyoderma in children, then herpes simplex virus, oral hairy leukopenia, varicella zoster virus, molluscum contagiosum virus, human papilloma virus infections are common. Fungal infection in CNS, we have cryptococcosis. In GIT, we have candidiasis. In lung, we have pneumocystis jirovecii pneumonia. In mucocutaneous candidiasis, others are penicillinosis. Protozoal infection in CNS, we have toxoplasmosis. In GIT, there is a long list: cryptosporidiosis, giardiasis, strongyloidosis, microsporidiosis, isosporiasis, and amoeba histolytica. Other illnesses which are most common in CNS are age dementia complex due to progressive multifocal leukoencephalopathy, non-Hodgkin lymphoma, and invasive cervical carcinoma. So you can see the diseases according to the CD4 count. So the sign of HIV infection and CD4 decline. You see when the CD4 counts fall to 400, we see herpes zoster virus. When it falls to 300, we see oral candidiasis, and so on like this. But TB can occur at any stage of CD4 count. So now we will be seeing the mucocutaneous manifestation of HIV infection. In skin, most commonly affected organ in patient with HIV. With more than 90% of HIV infected patients have skin or mucocutaneous symptoms. Cutaneous infection can occur at any stage of HIV infection. Skin manifestation have diagnostic and prognostic significance. As with different viral load and CD4 count, manifestations are different. This is helpful in situations where facilities of CD4 count and viral load are not easily available to monitor the progression. Skin, superficial skin, and mucosa contain lot of CD4 receptors bearing cell like Langerhans cells and fibroblasts. So, what is the we classify mucocutaneous manifestations like infectious, non-infectious, specific to mucosal manifestations, nail and hairs, and cutaneous adverse drug reaction due to antiretroviral therapy, that is Mulberry-Framresh, urticaria, angioedema, Stevens-Johnson syndrome, or toxic epidermal necrotising. What are the infections present in skin due to HIV? Viral infection in acute exanthema of HIV, herpes simplex, varicella zoster, Epstein-Barr virus infection, human papilloma virus, molluscum contagiosum, and Kaposi sarcoma. Bacterial infection, we have staph virus infection, mycobacterial and bacillary angiomatosis. Fungal infection, there is dermatophytosis, which is very severe, candidiasis, Malassezia purpura, trichosporosis, which causes extensive seborrheic dermatitis, deep and systemic mycosis, cryptococcus, histoplasmosis, and penicillosis. Parasitic infection, we have arthropod infection like scabies and democytosis, which are severe in form. We have crusted or scabies or Norwegian scabies in HIV infected patient. This protozoal infection like pneumocystis, toxoplasmosis, and leishmaniasis. What are non-infectious manifestations of HIV? There is dryness and eczema, seborrheic dermatitis, psoriasis, papular pruritic eruptions, pruritus of HIV, pigmented disorders, cutaneous adverse drug reaction, and neoplasm. What are the specific mucosal infection? There is abnormal mucosal pigmentation, viral infections like oral hairy leukopenia, herpes simplex, zoster, and human papilloma virus, oral ulceration, fungal infection like oral candidiasis, and malignancies like Kaposi's and non-Hodgkin's lymphoma. Then we have nail and hair manifestations. The nail manifestations are onychomycosis, yellow discoloration, melanotic bands, and black pigmentation due to pseudovidin. What are the hair manifestations are premature graying of hair, diffuse hair loss, male pattern baldness, alopecia areata, and long eyelashes. So herpes, let's see individual diseases. Herpes simplex virus infection, HSV type 1 and 2. HSV1 causes oropharyngeal erosion and HSV2 causes genital lesions. These are the most common opportunistic infection in HIV infected patient. HIV, HSV double trouble. They co-transmit each other. Acute outbreak of herpes simplex virus infection accelerate HIV disease progression. There is twofold increase of HIV acquisition in patient having genital herpes. HIV positive cases with herpes simplex virus infection shed more herpes. What are the clinical features of herpes simplex virus? There is chronic herpetic ulcer on more than 1 month duration in an AIDS-defining condition. These are tender, painful, giant ulcerative lesions in genital and perianal area and lip, which is the hallmark of HIV-infected patient. As immunodeficiency progresses, this infection becomes more chronic, progressive, recurrent, and less responding to the antiviral therapy. Early administration of acyclovir 400 mg 3 times a day will complete healing, or famciclovir 250 times a day, or valacyclovir 1 gram twice a day. IV foscarnet is given for acyclovir resistant herpes simplex virus. You can see the cases of herpes labialis and herpes progenitalis pre-treatment and after treatment with viral drugs, antiviral drugs. Then we see herpes zoster in HIV/AIDS caused by varicella zoster virus. Since varicella zoster virus causes varicella in normal children, herpes zoster in young children should alert the physician to possibility of HIV infection. In HIV positive cases with immunosuppression, it occurs in younger population is recurring, hemorrhagic, disseminated, and multi-dermatomal. Some cases develop herpes zoster ophthalmicus. Treatment is Oral acyclovir 800 milligram 5 times a day till complete healing is treatment of choice. Alternatively, we can give famciclovir, valacyclovir, preferably within 3 days of appearance of rash. You can see multidermatoma zoster and aspil zoster ophthalmicus in the photographs. You see, we have photographs of severe HIV positive children having severe chickenpox or varicella, and also there are features of herpes zoster in HIV positive children. Then we see molluscum contagiosum virus infection. It is caused by DNA virus, poxviridae family, that is skin umbilicated pearly white papules. The lesions tend to be numerous in HIV, widespread, and maybe nodular. They are often called giant molluscum. Extragenital giant molluscums are the marker of AIDS. Treatment ART is very effective in addition to conventional method like cryo, electrodissection, gentle curettage. For resistant cases, topical immuno 5% and topical or intravenous cidofovir can be used. And we see Kaposi sarcoma. It is caused by human herpes virus type A. The mode of transmission is sexually probably more fecal-oral route or ejaculate rather than blood in HIV positive homosexual men. The classical lesion is a purple black patch, plaque or nodule which may ulcerate. Aggressive course in HIV, especially among homosexuals. Treatment, the response to ART is unpredictable, specific local or systemic therapy often instituted. Then HIV people also have severe human papilloma virus infection. They are more prone for this infection. These are cutaneous and anogenital warts, also called as condyloma accumulator, caused by HPV infection during the course of HIV disease. They can be extensive, numerous, and resistant to therapy. 16 and 18 are the associated with carcinoma in situ cervix, vagina, and rectum with high-grade dysplasia. Invasive cervical cancer is aggressive in nature and is an AIDS-defining condition. Treatment is topical imiquimod, podophylotoxin, liquid nitrogen, cidofovir. ART can lead to decrease in the size. Oral HPV can be treated with 1 to 3% of cidofovir solution. Preventive vaccine for HPV-related carcinoma, recombinant quadrivalent vaccine and bivalent vaccines are available for HPV. Then you see the giant genital wart, also called as Bush-Tillotson tumor. The etiology we all know in papilloma virus. You see Ori hairy leukopelia correlated appearance occurs with low CD4 count caused by Epstein virus. Then what are the bacterial infections? Staph, mycobacterial, bacillary enteromycosis, Staph palladium, and others. Staph aureus most commonly bacterial pathogen causing cutaneous and systemic infections in HIV patients. Up to 80% patients with AIDS suffer from Staph aureus infection and more, which is more in children. What are these infections? These are bullous impetigo, ecthyma, staphylococcus skin, scarlet syndrome, folliculitis, furuncle, carbuncles, cellulitis, and hidradenitis suppurativa. Now you'll see bacillary angiomatosis. It's a vascular proliferative response to infection of with a gram-negative cat-state disease organism, Bartonella hansel and Bartonella quintana. Usually occurs when CD4 count is less than 200. Clinical features shows as solitary or multiple small red papule, pinpoint-sized papule that increase in size to form nodules and tumors. Diagnosis is made by hematoxylin eosin Barton staining. Treatment of choice is erythromycin 500 milligram 4 times a day, given for 3 to 4 weeks. Then other bacterial infection is cutaneous tuberculosis. Although TB is common, HIV exclusive cutaneous presentation is more common. Diverse clinical presentation like scleroderma, scattered, bilacious papules, keratotic papules, and nodules, tuberculosis. Clinical response is not always characteristics. Response is to ATT is confirmatory to the diagnosis. Always suspect TB in a non-healing cutaneous ulcer, not responding to active antibacterial or antiviral treatment. Then we'll see fungal infection, most commonly occurring fungal infection, candidiasis. The oropharyngeal candidiasis is the most frequent opportunistic fungal infection affecting 90% of, more than 90% of HIV patients. There can be oropharyngeal, esophageal, or vulvovaginal. Etiology, the most common positive organism is Candida albicans. There is cottage cheese-like creamy white exudative plaques on tongue, which can be easily removed and leave inflammatory erythematous surface. Treatment is fluconazole 100 milligram daily for 14 days. Then oropharyngeal candidiasis is an age-defining illness. You can see the various photographs of candidiasis. You see angular cheilitis, cottage cheese appearance, oropharyngeal candidiasis. Then we have dermatophytosis. Dermatophytosis in HIV patient is more varied, extensive, and atypical than in immunocompetent individual. Lesions may be atypical with lack of active edge and central scaling. Treatment is systemic antifungal therapy with itraconazole, fluconazole, terbinafine, or various topical azoles, clotrimazole, cetirizine, and luminosole. Then other arthropod infections, scabies, occurs at any stage of CD4 count, but the manifestation is more common, more severe at lower CD4 counts. Usually manifests as I told you before, crusted or non-raging scabies, with patient infested with hundreds to thousands of adult female mites. Treatment is scabicides like 5% permethrin and 1% gamma benzene hexachloride along with single dose oral ivermectin 200 microgram per kg single. We see non-infectious dermatosis of papular and follicular eruptions. Papules which are transient to 4 to 6 weeks or greater than 6 weeks. Chronic papulofollicular. For follicular, we have Staph aureus and eosinophilic folliculitis. Other causes are pruritus, prurigo nodularis, and insect bite reaction. So now we'll go for lab diagnosis of HIV. The specific antibody detection is done by ELISA, immunoabsorbent assay, enzyme immunoassay, rapid test, Western blot. The window period is 3 weeks to 6 months. Rapid test is recommended. Western blot is confirmatory test with high specificity. Specific antigen test is done is positive in 7 to 10 days. It's for detection of P24 antigen or reverse transcriptase assay. It is highly specific, but sensitivity is very low. And fourth generation ELISA detects P24 antigen and antibody reduce window period. Like it is not positive in 16 days, but after 16 days it becomes positive. All the specific ELISA tests are positive after 3 weeks, and specific antigen test becomes positive after 10 days. Then detection of viral nucleic acid, they are also have low window period. That means they are diagnosed, can be diagnosed after 10 days. These are qualitative DNA, RNA, PCR test, nucleic acid amplification test, called this. They are highly specific and sensitive. These are detection of used for detection of HIV during window period, recent blood transfusion, high risk sexual exposure, and needle stick injury. Then isolation or viral culture, which is it takes time and it is not feasible and it is only used for research settings. What are the prerequisites for HIV testing? There are three C's: consent, counseling, and confidentiality. We have informed consent. We have to take informed consent from the patient that we are doing HIV test for you. Then we have to counsel the patient before the test that the test can be positive. Then you should not be panic. We will have treatment and you can have a normal life with healthy food and all the medicines. And the confidential is also very important. Then post-test counseling, which is done at if the test is positive, then patient is referred to ART center. If negative, the subject is considered regarding the to reduce the high risk sexual behavior. Then how to monitor immune deterioration or prognosis? We have to do CD4 lymphocyte count. It is the most important marker of immunological status of an HIV patient. Level of CD4 correlates with occurrence of opportunistic infections. Secondly, plasma viral load. Plasma viral load detects exact quantity of virus in plasma, best measured by trans-DNA signal amplification test. Other techniques are reverse transcription, polymerase chain reaction, and nucleic acid sequence-based amplification. Plasma viral load and CD4 count are the most important predictors of progression to AIDS and the prognostic markers of HIV in response to ART. Then combination of active retroviral therapy, which we use in treatment. And what are the goals for this treatment? The clinical goal is prolongation of the life and improvement of the quality of life. Virological goals is maximal and double suppression of viral load less than 50 copies per ml so that we can halt the disease progression. The immunological goal is preservation of immune system, recovery of immune system. Therapeutic goal is the rational sequencing to maintain therapeutic options relatively free of side effects, realistic in terms of adherence. The patient have minimum side effects and we should adhere to the treatment and take the treatment properly. What are the epidemiological goals? So we have to reduce the HIV transmission. We have to increase the test and treat policy. This renders the patient non-infectious. Plasma viral load becomes undetected within 6 months after starting ART. If HIV plasma viral load is undetectable, HIV is untransmissible. So, what are the targets of HIV antiretroviral drugs? There are various types of antiviral drugs which acts at different stages of HIV cycle. That means that on other various stages of HIV virus multiplication and its protein synthesis, like fusion inhibitors. We have CCR5 receptor antagonist. If we will make, then we have protease inhibitors, which stops protein cleavage. Then we have reverse transcriptase inhibitors, and we have integrase inhibitors. So now we'll see in detail the classes of drugs available. Nucleoside reverse transcriptase inhibitor. These are zidovudine, lamivudine, abacavir, amitriptyline. Then we have non-nucleoside reverse transcriptase inhibitors, yeah, which are nevirapine, efavirenz, delavirdine, rilpivirine, etravirine. Then we have fusion inhibitors, enfoveritide, P20, integrase inhibitor 3 are deltagravir, eltigravir, dolutegravir. Then we have HIV CCR5 entry inhibitors, naravirol. We have protease inhibitors. We have boosted protease inhibitor, which are lipovir, retinovir, Adsavir, darunavir. We have non-nucleotide reverse transcriptase inhibitors, tenofovir disoproxil fumarate, tenofovir alpha-minimum. So first line regime for ARTs in adults and adolescents is we combine three drugs in fixed dose combination. If it is contraindicated or not available, one of the following option is recommended. There is all the combinations you can see. What antiretroviral drugs commonly used in anti drug? What are the adverse reactions commonly we see in antiretroviral drugs like NRIT causes mitochondrial toxicity. Zidovudine causes anemia, low leukocyte count, nausea, fatigue, headache, myopathy. Dermatological side effects are nail and skin hyperpigmentation. Lamivudine causes minimal toxicities, rash, though very rare. Tenofovir causes renal toxicity, bone demineralization. Abacavir causes hypersensitivity, reaction in 3 to 5%, which can be fatal. NNRTI causes rash, in which nevirapine is the most common cause, generally mild and safe. Rifampicin causes CNS side effects, nightmare, dizziness, rash, hepatotoxicities, and lipid abnormalities. Nevirapine causes rash, which usually seen in first 2 to 8 weeks, higher in women, more if higher CD4 count is present, severe rash or Stevens-Johnson syndrome. It also causes hepatotoxicities. Protease inhibitor causes GI intolerance, altered taste, abnormal liver function test, and bone disorders. All have been associated with metabolic abnormalities such as hyperglycemia, insulin resistance, and increase in triglycerides, cholesterol, and body fat distribution. You can see the side effects of antiviral drugs, nevirapine causing Stevens-Johnson syndrome, and zidovudine induced longitudinal hyperpigmented band on thumbnail. What is immune reconstitution inflammatory syndrome? Paradoxical deterioration in clinical status in patient on ART despite satisfactory control of viral replication and improvement of CD4 count. This is an inflammatory response towards previously diagnosed or incubating opportunistic pathogen as well as response towards other as yet unidentified antigen. Frequently occurring cutaneous IRIS event includes TB, herpes simplex, and herpes zoster. Appearance of opportunistic infection within a period of 8 to 12 weeks after initiation of ART should be identified as immune reconstitution inflammatory syndrome. Risk of development of immune reconstitution inflammatory syndrome is more if 34% at the time of initiation of ART is less than 15%, and those who have more rapid rise in CD4 count after initiation of ART. Then what is the post-exposure prophylaxis? Hair care personnel can come in contact with blood or body fluids of HIV infected cases, thereby at potentially risk of contracting HIV. So what is the risk of HIV transmission due to occupational exposure? Percutaneous injury, overall risk is 0.18% to 0.3%. Then hollow bone needle, there is 0.18% risk. Scalpel injury, 0.28%. Mucous membrane exposure to fluid is 0.09%. Non-intact skin exposure will below 0.9%. Intact skin, there is nil. Risk of hepatitis B virus transmission is 9 to 30%. Risk of hepatitis C virus transmission is 3 to 10%. Post-exposure prophylaxis with ART initiated as early as possible within 2 hours and not after than 72 hours can protect healthcare professionals. Whether the material is the bloody fluid, or other potentially infected material or instrument contained with one of these substances. If yes, we have to see what kind of exposure occurred. If there is mucous membrane exposure or skin integrity compromise, then we have to see the volume. If the small volume of few drops occur, then we go for EC1. Then if the large molecule or major splash or long duration occur, then we go for EC2. If then exposure on intestine, no post-exposure prophylaxis required. If there is percutaneous exposure, then we have to see the severity. If less severe, solid needle or superficial scratch, we go for EC2. If there is more severe hollow bone injury or deep injury, we go for EC3. HIV status of source. If it is HIV negative, then no post-exposure prophylaxis required. If it is HIV positive, if there is low titer asymptomatic high CD4 count, then HIV SC1. If high titer exposure advanced disease, low CD4 count, then HIV SC2, schedule 2. If source of HIV status unknown, then HIV SC. Then these are various codes for exposure and source, recommendation for post-exposure prophylaxis, and duration of post-exposure prophylaxis. If source code is 2, there is recommendation of PEP. PEP is recommending for 28 days, and source code is 2 and 3 are unknown. Then consider PEP if high prevalence in high giving population and risk categorization, and the duration of treatment is 28 days. And what are the recommendations for adults? These are the various combination for one. There is combination of one tablet immediately after 2 hours for accidental exposure, or plus you can give ritonavir, lopinavir, and 2 tab FDC twice daily. 2 tablets immediately within 2 hours of accidental exposure. If lopinavir is not available, not to be used, then tenofovir, lamivudine, efavirenz, 1 tablet OD. All regimen is to be continued for 4 weeks. So, what are the post and pre-sexual exposure prophylaxis? Post-sexual exposure prophylaxis, the principle is same as occupational post-exposure prophylaxis. It can be used in cases of sexual assault, unprotected sexual contact with known HIV positive partner. What are the pre-exposure prophylaxis? Administration of ART to an uninfected person before potential HIV exposure to reduce the risk of HIV infection and continue during risk. Risdiplam, tenofovir 300 mg and emtricitabine 200 mg. Non-consensus about initiation and duration. It is effective if taken daily. If not, it does not offer offer protection against other STI. It is an option for standard protective measure. HIV prevention. What are the things we have to use? Save blood, save sex, universal precaution in hospital setting. Save sex. ABC, like abstinence before marriage, be faithful, monogamous relationship with single partner, condom. Correct and consistent use of condom. There is resistant to use male condom. Need of the hour is availability of female-driven proprietary devices like female condoms and vaginal microbiocides. A female condom is a pre-lubricated polyurethane sheath which covers the introitus in toto, and it is available. HIV prevention, safe sex, safe blood, and universal precautions in hospital sector. Blood safety. Blood donated from voluntary donor is ideal when needed. It must be tested negative to HIV, hepatitis B, and hepatitis C. Universal precaution at workplace are hand wash, barrier precaution, use of latex gloves, and if required, goggles, previous protective apparel, adaptation of standard practices of sterilization and disinfection, use of time-tested disinfectants like ethanol, hypochlorite, glutaraldehyde, povidone iodine, proper disposal of hospital waste, clean habits and common sense prevents HIV transmission. Only 1% in the world can protect you from AIDS. It's you, yourself. Now, towards the cure, what are things can be done for curing? There might be vaccine, neutralizing antibodies, and stem cell transplantation. Main barrier to a sterilizing cure is the presence of latent reservoir. The population of HIV infected cells grows persistent for a lifetime despite ART, lack of HIV specific immune response. Eliminating the viral reservoir make the latent virus susceptible for ART. Allogenic hematopoietic stem cell transplantation from a donor homozygote to HIV resistant CCR532 mutation, alteration of host genome using genetic engineering techniques, kick and kill, also known as shock and kill, altering the immune system for better clearance of HIV infected targets, hit early and hit hard. Treatment is in early stage of infection are common. HIV infection is the only way to end the HIV epidemic. Innovative strategies to design vaccine immunogens capable of activating both arms of adaptive immune response, antibodies and T cells, B cell immunogens that simulate the B cells to generate broadly neutralizing antibodies against the virus are now in clinical trials. T cell immunogens intended primarily to elicit broadly reactive potent antiviral T cell response against the virus. What are the challenges? We have genetic variability of the virus, its ability to quickly establish a persistent long life infection. Innovative vaccine delivery technologies, recombinant vesicular stomatitis virus vector that incorporates an HIV envelope gene to use mRNA to direct cell to make proteins that will elicit immune response against HIV. This ends our HIV topic. Thank you very much.